Most people have a clearer picture of what it means to be physically healthy than of what it means to be mentally healthy. We know what a healthy cardiovascular system looks like. We know what healthy blood pressure and body composition and sleep architecture look like. We have biomarkers, we have reference ranges, we have frameworks for assessment. But when it comes to mental health, most people are working with something much vaguer, the absence of diagnosable illness, or the feeling that things are more or less okay, or the sense that they are not as bad as they could be. That is not a framework for mental health. That is the absence of a framework. And the consequence is that people spend years, sometimes decades, in states of low-grade suffering, anxiety, negative self-talk, and disconnection from themselves that they could address if they had a clear map of what mental health actually is and what it requires. Today's guest has spent his career building that map. Welcome to the Huberman Lab podcast, where we discuss science and science-based tools for everyday life. I am Andrew Huberman, and I am a professor of neurobiology and ophthalmology at Stanford School of Medicine. My guest today is Dr. Paul Conti. Dr. Conti is a psychiatrist who trained at Stanford School of Medicine and completed his residency at Harvard Medical School, where he was appointed chief resident. He is currently the CEO and founder of the Pacific Premier Group, a clinical practice in Portland, Oregon. He has spent his career treating the full spectrum of mental illness and the impact of life stressors on psychological well-being. And he has developed a framework for understanding the structure and function of the self that I consider one of the most practically useful frameworks I have encountered for understanding what mental health actually is and what it requires. This is the first episode in a 4-part series on mental health with Dr. Conti, and I want to be clear about what this series is and what it is not. It is not a replacement for professional mental health care. If you are struggling with serious mental illness, please seek the help of a licensed mental health professional. What this series is a foundational roadmap, a way of understanding the structure of the mind and the self that allows you to assess your own mental health with much greater precision than the vague feeling of more or less okay allows, and to identify specific areas where attention and work are needed. Everything in this episode applies to every human being, not just those with clinical diagnoses, because the architecture of the mind that Dr. Conti describes is universal, and the tools he provides are available to anyone willing to do the work of genuine self-inquiry. Timestamps are in the description below. Before we begin, let me briefly thank our sponsors. Without further ado, my conversation with Dr. Paul Conti. Paul, I want to start with the most fundamental question, which is what mental health actually is. Because I think the standard definition that most people operate with, essentially the absence of mental illness, is not adequate. It does not give people a positive target to aim at. It does not tell them what they are trying to build. So I want to begin there. How do you define mental health in terms that are actually actionable? The framework I have developed begins with a recognition that mental health is not simply the absence of illness, just as physical health is not simply the absence of disease. You would not say that someone whose blood pressure is in the borderline range, who has poor metabolic health, who is sedentary and chronically sleep deprived, is physically healthy simply because they have not yet been diagnosed with a specific disease. The absence of diagnosis is not health. Health is a positive condition with specific qualities. And the same is true for mental health. The specific qualities of a genuinely healthy mental state are, in my framework, 2 in particular: agency and gratitude. And I want to be precise about what I mean by each. Agency is the felt sense of active engagement with your own life. It is the experience of being a participant in what happens to you rather than a passenger. It does not mean control over all outcomes. It means the experience of moving through life with intention, with the sense that your choices matter, that your engagement with circumstances is genuine and generative rather than reactive and contracted. Gratitude is not the practice of telling yourself things are fine when they are not. It is a genuine orientation toward life, an appreciation for the experience of being alive, for the connections you have, for the capacities you possess that persists even through difficulty. And what is striking about this definition, when you look across traditions, across psychiatry and psychology, across literature and religion and philosophy, is how consistent it is. The people who are described as deeply mentally healthy, who age with grace, who navigate difficulty without being destroyed by it, who contribute to others in meaningful ways, almost universally are described in terms that map onto agency and gratitude. They are engaged, they are appreciative, they are not passive, and they are not resentful. Agency and gratitude are the target. Everything else in the framework I am going to describe is about understanding what prevents people from reaching that target and what supports their movement toward it. I find that framing genuinely useful because it gives people something to assess themselves against. Not a clinical threshold, but a lived quality. And when you put it that way, I think a lot of people will recognize that they do not feel that quality in their lives consistently. They have patches of it, but they do not have it as a stable orientation. What is the architecture of the mind that determines whether someone arrives at agency and gratitude or not? This is where the framework becomes more specific and I think more practically powerful. The architecture I describe has several layers. I call them the structure and function of the self. The structure is the nouns, the components, the function is the verbs, what those components do, and understanding both is necessary for understanding where things go wrong and what can be done about it. The deepest layer of the structure is the unconscious mind. And I want to be very specific about what I mean by the unconscious, because it is a word that carries a lot of baggage from popular culture and from outdated versions of psychoanalytic theory. And I want to strip that baggage away and describe what the unconscious mind actually is at the level of neuroscience and clinical observation. The unconscious mind is the vast, largely inaccessible processing infrastructure of the brain. The neuroscientists would say it is the overwhelming majority of what the brain does at any given moment, the processing that does not rise to conscious awareness. Research on the neuroscience of decision-making, on implicit memory, on automatic behavior, and on the predictive processing that underlies perception consistently suggests that conscious awareness is the tip of a very large iceberg of mental activity. The unconscious is not a repository of repressed desires in the Freudian caricature. It is the ongoing computational substrate of everything your brain does. And it has a profound and continuous influence on your conscious experience through several mechanisms. It shapes your emotional tone, your automatic reactions, your implicit beliefs about the world and about yourself, your patterns of attention and interpretation, and your behavioral tendencies. All of these arise from the unconscious processing and then present themselves to the conscious mind as the felt reality of your experience. The metaphor I find most useful is the iceberg. The conscious mind is the portion visible above the water. The unconscious is the much larger portion beneath the surface. The visible portion is real and it matters. But its shape and its stability are determined by what is beneath the surface in ways that are not immediately visible. The research literature on implicit cognition supports this framework directly. Research on what Timothy Wilson at the University of Virginia calls adaptive unconscious and on implicit association testing developed by Anthony Greenwald and colleagues has shown that people carry implicit beliefs, attitudes, and biases that are genuinely inaccessible to introspection and that significantly influence behavior, sometimes in directions that are directly contrary to the person's explicit stated beliefs. You can believe consciously that you value equality and simultaneously carry implicit biases that shape your behavior in ways inconsistent with that belief, and the inconsistency will not be visible to your own introspection without specific tools. This is not a moral failing. It is a description of how the mind works, and it has direct implications for mental health because many of the patterns that produce suffering, the anxiety, the negative self-talk, the low confidence, the overthinking, are driven not primarily by the conscious mind, but by the unconscious processing that feeds into conscious experience. Addressing the conscious symptom without addressing the unconscious source is like turning off a smoke alarm without addressing the fire. That is a really important point, and I want to make sure we spend sufficient time on it. But first, can you describe the next layer up in your framework, which is the defense mechanisms? The defense mechanisms are the second major structural component of the self. And again, I want to give this concept the precision it deserves rather than the caricature that popular understanding often reduces it to. Defense mechanisms are unconscious psychological strategies that the mind uses to protect the conscious self from experiences that would be overwhelming, destabilizing, or unbearable. The key word is unconscious. You do not decide to use a defense mechanism. The mechanism arises automatically, below conscious awareness, in response to internal or external stimuli that the unconscious processing has categorized as threatening. The conscious experience is not of defending yourself. The conscious experience is of the world looking a certain way, of people behaving a certain way, of situations meaning certain things. The defense mechanism shapes that interpretation without announcing itself. Sigmund Freud and Anna Freud describe defense mechanisms in ways that establish the foundational vocabulary. Contemporary psychiatry and psychology have expanded and refined that vocabulary substantially. The mechanisms I consider most important to understand for practical mental health are projection, displacement, projective identification, sublimation, rationalization, avoidance, and denial. Let me describe each of these with enough precision that they become recognizable in your own experience. Projection is the mechanism by which we attribute to others an internal state that is actually our own, but that is too uncomfortable to own consciously. The classic example, you are late for work, stuck in traffic, feeling frustrated and angry. Those feelings are real, but their source is internal, the situation you have created by your own choices or circumstances. Through projection, the frustration gets attributed to the other drivers. They become the hostile, aggressive, unreasonable ones. Your own anger becomes visible to you only as a property of the external world. The road rage is projection. You are not owning the anger as yours. You are seeing it as out there. The practical consequence is that projection creates a distorted picture of reality. If you chronically project your internal states onto others, you will consistently perceive the world as more hostile, more critical, more threatening than it actually is. And you will respond to that perceived hostility in ways that generate real hostility from others, which then appears to confirm your perception. This is a self-reinforcing loop that produces chronic, distorted experience without any conscious awareness that the distortion is happening. Displacement is related but distinct. Where projection attributes an internal state to an external source, displacement redirects an internal state toward a different target. You have a terrible day at work. Your boss criticizes you unfairly. You cannot express the anger toward your boss because that would be dangerous. So you come home and you take it out on your partner or your children or your dog. The anger is real and it is yours. You are not denying it or attributing it to someone else. You are redirecting it toward a target that feels safer. The cost of displacement is that the people in your life who are not the actual source of your frustration become the recipients of it. Your closest relationships absorb the emotional content that your defense mechanism prevents you from processing at the appropriate source. Projective identification is perhaps the most sophisticated and the most socially significant of these three mechanisms. It is the process by which an internal emotional state is not just attributed to another person or redirected at another person, but actually induced in them. The person experiencing the emotion communicates it, often through subtle, tonal, behavioral, and nonverbal channels, in a way that makes the other person feel that emotion. You are feeling anxious and agitated. You are not consciously expressing that anxiety, but the way you move, the tone of your voice, the content and pacing of what you say communicates the agitation in ways that other people pick up. And before long, the people around you are feeling anxious and agitated themselves without necessarily knowing why. The emotion has spread. This is why being in the presence of certain people is consistently draining or destabilizing. They may not be doing anything overtly problematic, but their internal state is being communicated through projective identification in ways that affect those around them. And the mechanism operates in both directions. The same process allows for the positive contagion of calm, of warmth, of enthusiasm. The person whose internal state is genuinely regulated and genuinely positive communicates that in ways that actually help regulate the people around them. Let me now describe the more adaptive defense mechanisms, because I want to be clear that defense mechanisms are not inherently pathological. They are a universal feature of human psychology. The question is whether the specific mechanisms a person predominantly uses are adaptive or maladaptive, and that distinction is crucial. Sublimation is the process by which difficult internal states, aggression, grief, sexual energy, frustration, are channeled into constructive activities. the athlete who trains with ferocious intensity because they are channeling aggressive energy that would otherwise create interpersonal problems, the artist who makes extraordinary work from grief, the entrepreneur who builds relentlessly partly because early experiences of powerlessness created an internal drive toward agency. Sublimation is the conversion of difficult internal material into something generative. It is one of the most psychologically healthy defense mechanisms and one of the primary mechanisms by which difficult life experiences produce extraordinary outcomes. Rationalization is the mechanism by which the mind constructs a plausible sounding logical explanation for behavior or feelings that are actually driven by other, less comfortable motivations. You do not take the job offer partly because you are afraid of failing, but the reason you construct consciously is that the compensation package was not quite right and the commute would have been difficult. The rationalization is not entirely false. The compensation and the commute are real considerations, but they are not the primary driver. The primary driver is fear, and the rationalization protects the conscious mind from having to see that. Avoidance is exactly what it sounds like. Not engaging with situations, relationships, internal states, or topics that produce discomfort. It is extraordinarily common and extraordinarily costly over time because the things we avoid do not resolve themselves. They accumulate unprocessed grief, unexplored anxiety, unaddressed relational patterns. All of these accumulate in the unconscious and generate symptoms that become more severe over time precisely because they are not being addressed. This brings me to the character structure, which is the third major component of the structural framework. And this is the concept that I find most practically powerful for helping people understand their own mental health. The character structure is the nest, to use the metaphor I find most useful, that surrounds the unconscious mind and the defense mechanisms. And that constitutes the way you habitually engage with the world. It is not simply your personality or your temperament, though it includes both. It is the predispositions you bring to every situation, the lens through which you interpret experience, the automatic orientations that determine how you respond before the conscious mind has fully processed what is happening. Think of it this way. Your character structure determines whether you approach novel situations with curiosity or with suspicion. It determines how much you rationalize when things go wrong. It determines your default relationship to other people, whether you extend trust readily or withhold it until trust is earned. It determines how you handle conflict, how you respond to criticism, how you relate to your own needs and vulnerabilities. These are not fixed or immutable, but they are consistent enough across contexts that they function as a stable orientation. And the health of the character structure, whether it is flexible and curious and oriented toward engagement and growth, or rigid and defended and oriented toward self-protection, is one of the primary determinants of whether a person arrives at agency and gratitude or remains chronically defended and contracted. The relationship between the defense mechanisms and the character structure is intimate. The character structure is partly constituted by the defense mechanisms that have become the person's habitual ways of managing internal distress. A person who predominantly uses avoidance as a defense mechanism will have a character structure that is generally avoidant, that orients away from difficulty and toward comfort, that has limited practice and limited tolerance for the discomfort of genuine engagement with challenging material. A person who predominantly uses projection will have a character structure that is generally oriented toward seeing the problem as external, as located in others or in circumstances, which produces a particular kind of relational pattern and a particular kind of experience of the world. And the good news, the clinically and practically important good news, is that character structure is changeable. It is not destiny. The character structure that developed in response to the specific circumstances of your early life, including the experiences of caregiving, of safety and danger, of being seen or not seen, of being supported or not supported, is the character structure that was adaptive to those circumstances. But it is not necessarily the character structure that best serves your adult life. And it can be changed through the specific kind of conscious, curious self-inquiry that this entire framework is designed to support. Now let me describe the function of the self, which is distinct from the structure. If the structure is the nouns, the function is the verbs. What does the self actually do? The function of the self begins with self-awareness, which is the most fundamental functional capacity. It is the capacity to observe your own thoughts, feelings, behaviors, and patterns with some degree of clarity and objectivity. Not perfectly, because perfect self-observation is not possible given the nature of unconscious processing, but with enough clarity to identify the patterns that are shaping your experience and behavior. Self-awareness is not the same as self-monitoring or self-consciousness, which are often anxious and contracted forms of attending to oneself. Genuine self-awareness has a quality of curious, non-judgmental observation. You are looking at yourself the way a scientist looks at a phenomenon of interest, with genuine curiosity about what is there, rather than with a predetermined verdict about whether it is acceptable or shameful. From self-awareness, the function of the self moves through defense mechanisms, through attention, through the patterns of behavior that express the character structure, toward what I call strivings. Strivings are the forward-looking element of the functional self, what you are moving toward, what you are building, what you want your life to look like and feel like. They are not goals in the external sense of specific achievements. They are more fundamental than that. The direction of your agency, the things you are choosing to invest your attention and your energy in. When the structure of the self is healthy, meaning the unconscious mind is relatively free of unprocessed trauma and conflict, the defense mechanisms are predominantly adaptive, and the character structure is flexible and curious. The strivings tend to be genuinely generative. They tend to be oriented toward things that actually serve the person's well-being and the well-being of those around them. When the structure is not healthy, the strivings can be driven by the unconscious content in ways the person is not aware of, oriented toward avoiding feared outcomes rather than pursuing genuine desires, organized around the defense mechanisms rather than around the person's actual values and wants. Let me now go into the specific psychological states that most people identify as their primary mental health challenges: anxiety, low confidence, negative internal narratives, and overthinking. Because I want to show how each of these connects back to the structural framework I have described and how that connection makes the path to addressing them more specific and more actionable. Anxiety is, in the clinical sense, the experience of threat in the absence of immediate danger. The threat is real in the sense that the nervous system is generating a genuine threat response, but the threat is not located where the anxious person perceives it to be. Most chronic anxiety, in my clinical experience and in the research literature, is not a response to actual present danger. It is a response to internal material, unprocessed emotions, unresolved conflicts, unconscious beliefs about the world and about the self that the nervous system is treating as threatening. The iceberg metaphor is useful here. What is above the surface, the conscious experience of anxiety, is real and it is distressing, but the source is beneath the surface in the unconscious processing that is generating the anxiety signal. This is why treating anxiety purely at the level of symptoms, through reassurance, through avoidance of anxiety-provoking situations, through cognitive techniques that target the conscious anxious thoughts, often has limited long-term effectiveness. You are managing the smoke alarm without addressing the fire. The more effective and more durable approach is to develop curiosity about what is generating the anxiety, to move attention down into the unconscious material that is driving it. And the first step in that process is simply the willingness to ask the question, what is this anxiety actually about? Not what situation seems to trigger it, though that is relevant information, but what is this anxiety telling me about something that I have not fully looked at in myself? The neuroscience of anxiety is relevant here. Research on the amygdala and its role in fear and anxiety processing shows that the amygdala generates threat signals based on pattern matching to prior threatening experiences. It does not distinguish reliably between current actual threats and situations that pattern match to historical threats. So a person who experienced significant insecurity or threat in childhood will have an amygdala that is calibrated to generate threat responses in situations that match those early patterns, even when the current situation is not objectively threatening. This is not a malfunction. It is the amygdala doing exactly what it evolved to do, which is to protect the organism by responding rapidly to anything that resembles a previously dangerous situation. The problem is that the calibration is based on historical data that is no longer necessarily relevant to the current environment. And addressing chronic anxiety at its most effective level involves updating that calibration, which requires accessing and processing the historical material that established it. Low confidence is the second major area I want to address. And I want to make a distinction that I consider clinically important, the distinction between confidence and its pathological substitutes. Genuine confidence is the accurate assessment of your own capacities combined with the willingness to act from that assessment. It is not the absence of doubt. It is not the feeling that you cannot fail. It is the grounded sense that you have capacities that are worth deploying, that you can learn what you do not know, and that your engagement with the world is worth something. The pathological substitute for confidence that I see most commonly is narcissism, which is the compensation for an underlying absence of genuine confidence through an inflated self-presentation. The narcissistic display of confidence is actually a defense mechanism, a way of protecting the conscious self from confronting the underlying conviction that it is not enough. And the tell is that it is brittle. Genuine confidence is robust to failure because it is grounded in an accurate self-assessment that includes the acknowledgement of limitation. Narcissistic confidence collapses when challenged because it was never grounded in accurate self-knowledge. It was a performance for the purpose of managing the internal feeling of inadequacy. Low confidence in the direct sense, the felt sense of inadequacy, of not being enough, of not being worthy of the things you want, almost always traces back to the character structure and to the unconscious material that shaped it. Early experiences of being told through word or circumstance that you are not enough, that your needs are not valid, that your presence is not welcome, leave traces in the unconscious that organize the character structure around a fundamental orientation of inadequacy. And those traces continue to generate low confidence as an experience long after the circumstances that created them have changed. The path to genuine confidence is not positive thinking. It is the honest, curious inquiry into the material that is generating the inadequacy experience, combined with the gradual construction of an accurate self-assessment that includes genuine acknowledgement of both capacities and limitations. The negative internal narrative is the third area I want to address, and it is one that I think is profoundly underestimated in its effects. The internal narrative is the ongoing stream of self-directed thought that characterizes conscious experience for most people. Researchers estimate that a significant proportion of conscious mental activity is self-referential, and that a significant proportion of self-referential thought in many people is negative, critical, or threatening. You are not smart enough. You are not attractive enough. You made a mistake. People think badly of you. You are going to fail. This stream is so continuous and so familiar that most people do not fully recognize it as something they are generating. They experience it as the voice of truth rather than as a habitual pattern of thought that has a history and a source. The negative internal narrative is almost always an internalization of something external. Messages received from caregivers, from peers, from cultural sources about the person's worth and capacity and acceptability that have been taken in and made the person's own inner voice. And the critical insight is that the internal narrative is not the same as truth. It is a pattern, and patterns can be examined and changed. The examination begins with what I call salience, which is a form of self-awareness applied specifically to the internal narrative. It is the practice of noticing the specific content of your self-directed thoughts with enough clarity to recognize the pattern. Not just the vague feeling of being hard on yourself, but the specific sentences, the specific scenarios, the specific qualities that the self-critical voice attributes to you. When you have that level of clarity about the content of your narrative, you can begin to ask where it came from, whether it is accurate, and whether it serves you. And almost invariably, the honest examination reveals that the negative internal narrative is less accurate than it feels, that it traces to sources that are no longer relevant, and that it is costing you something significant in terms of your capacity to engage with your life. Overthinking is the fourth major challenge I want to address, and I want to describe it in a specific way that connects it back to the structural framework. Overthinking is, in my formulation, The mind's attempt to use conscious analytical processing to solve a problem that is not amenable to conscious analytical processing because its source is in the unconscious. You are trying to think your way to a solution to an anxiety that is generated by unconscious content, and thinking cannot reach that content directly. So the thinking goes around and around, generating more thoughts, more scenarios, more analyses, without reaching resolution, because the thing that needs to be addressed is not in the place where the thinking is looking. This is why overthinking is so exhausting and so unproductive. It is not laziness or weak thinking. It is the application of the wrong tool to the problem. The right tool is curiosity directed downward toward the unconscious material that is generating the unresolved anxiety that is driving the overthinking. And the first step in accessing that material is simply stopping the thinking long enough to ask, what am I actually feeling right now underneath the thoughts? Not what am I thinking about feeling? What is the actual felt sense in my body and in my emotional experience right now? Because the unconscious communicates through feeling and through somatic experience in ways that thinking cannot access. The practice of dropping below the thoughts into the felt sense is not mystical. It is a specific attentional shift that allows access to material that the default mode of conscious analytical processing keeps you above. Let me now describe the practical tools for self-inquiry that follow from this framework, because I want to close this conversation with something that is immediately actionable for anyone listening. The first and most fundamental tool is curiosity. Not the curiosity of, I wonder if I have problems, but the deep, genuine, non-judgmental curiosity of wanting to understand what is actually happening inside you. Curiosity is the opposite of judgment. When you approach your own internal experience with judgment, which is what most people do most of the time when they attempt self-reflection, the defensive structures activate. You encounter something uncomfortable, and the defense mechanisms protect you from it before you can fully see it. When you approach with genuine curiosity, the same way you would approach an interesting puzzle or an unknown phenomenon in the world, the defensive activation is reduced. You are more able to actually see what is there. The second tool is what I call looking at behavior as data. Your behavior, the specific choices you make, the patterns that repeat in your relationships and your work and your daily life, is the most honest data available to you about what is actually operating in your unconscious. Not what you intend to do, not what you believe about yourself, what you consistently do, and the consistent patterns of behavior are fingerprints of the underlying character structure and the defense mechanisms. When you notice a pattern in your behavior, rather than explaining it away, the question to ask is, what does this pattern tell me about what is operating in me that I may not be directly aware of? The third tool is attention to physical sensations as entry points to emotional experience. The body carries emotional information that the mind often defends against accessing directly. Tension in the chest or the throat or the belly, the quality of the breath, the pattern of muscle tension, these are somatic expressions of emotional states that the unconscious is generating. Learning to attend to these somatic signals as emotional data, rather than dismissing them as irrelevant physical sensations, is one of the most reliable ways to access unconscious material that the thinking mind cannot directly reach. The fourth tool is the deliberate engagement with your own history, not the official story of your life, the version you tell casually. The actual felt history. What were the experiences that shaped your sense of yourself and your sense of the world? What messages did you receive about your worth and your capacity? What were the relational patterns you were exposed to in your earliest and most formative relationships? This history is not determinative. It does not define you, but it did shape the character structure and the defense mechanisms that are currently operating. And you cannot fully understand the present operation of those mechanisms without some understanding of where they came from. The fifth tool, and the most important one in terms of practical urgency, is to ask the question that most people most consistently avoid: what am I afraid to look at? Because the things we are most invested in not seeing are the things that have the most power over us, precisely because we cannot see them. The avoidance itself is information. the specific topics, the specific memories, the specific aspects of your current life that you notice yourself steering away from, those are the areas where the most significant unconscious material is located. Not necessarily catastrophic material, often simply material that is uncomfortable to face, honestly. But the avoidance is costing you the agency that comes from seeing clearly, and the relief that follows honest confrontation with avoided material is one of the most consistently reported experiences in clinical practice. Let me close with the broader picture that all of these specifics are pointing toward. The goal of the inquiry, the goal of all the work described in this framework, is not to find out what is wrong with you. It is to develop the kind of accurate, curious, honest relationship with yourself that allows you to be genuinely present in your life, to act from your actual values rather than from your defense mechanisms, to engage with other people as they actually are rather than through the distorting lens of projection and projective identification, to pursue genuinely generative strivings rather than strivings that are organized around avoiding feared outcomes, to experience agency, the genuine felt sense of active, engaged participation in your own life, and to experience gratitude, the orientation of appreciation for what you have and what you are that is available even when circumstances are difficult. Those two experiences, agency and gratitude, are the markers of genuine mental health. They do not require perfect circumstances or the resolution of all your difficulties. They require the ongoing practice of the honest, curious self-inquiry that keeps the structure of the self clear enough to function well. And that practice is available to every human being willing to do it, with or without professional support. Professional support, when available and appropriate, can accelerate the process significantly. But the fundamental practice of honest self-inquiry is something every person can begin immediately. The first step is simply the willingness to be curious about yourself without judgment, to look at what is actually there with the same openness and genuine interest you would bring to any other phenomenon that mattered to you, because you matter to you. And your understanding of yourself is the most important knowledge you can possess. The key takeaways from today's conversation with Dr. Paul Conti: mental health is not the absence of illness. It is a positive condition characterized by two specific qualities: agency and gratitude. The experience of active engagement with your own life and the genuine orientation of appreciation for that life. Everything in this framework is organized around understanding what prevents those experiences and what supports them. The structure of the self has three components: the unconscious mind, which is the vast majority of mental processing and which profoundly shapes conscious experience through emotional tone, automatic reactions, implicit beliefs, and behavioral tendencies. The defense mechanisms, which are unconscious protective strategies that the mind uses to manage overwhelming or threatening internal experience, and which can be adaptive or maladaptive depending on which mechanisms predominate and how they are applied. And the character structure, the nest that surrounds the unconscious, and the defense mechanisms, which is the habitual orientation that determines how the person engages with the world. The specific defense mechanisms most important to understand are projection, displacement, projective identification, sublimation, rationalization, and avoidance. Each has a specific mechanism and specific consequences for how the person experiences and interacts with the world. The function of the self moves from self-awareness through the defense mechanisms, through attention and behavior, to strivings. And the health of each of those functional elements determines whether the person is moving toward agency and gratitude or away from them. The four primary mental health challenges: anxiety, low confidence, negative internal narrative, and overthinking, all trace back to the structure of the self and all respond to the same fundamental approach, which is curious, non-judgmental self-inquiry that moves attention toward rather than away from the unconscious material that is generating them. The 5 practical tools for that inquiry are developing genuine curiosity about your internal experience, treating your behavioral patterns as data about your unconscious, attending to physical sensations as entry points to emotional experience, deliberately engaging with the actual felt history of your early life and formative experiences, and asking the question that most people most consistently avoid: what am I afraid to look at? All of the research and resources connected to today's conversation are linked in the description below. Dr. Conti's book, Trauma, The Invisible Epidemic, is also linked. This is the first episode in a 4-part series on mental health with Dr. Paul Conti, and subsequent episodes will go deeper into tools and protocols for improving mental health, addressing trauma, and navigating specific life challenges. If you found today's episode valuable, please share it with someone who is working on their own mental health, because the framework we covered today provides a genuinely useful starting point for that work. Thank you for your time, and as always, thank you for your interest in science. I want to add several more dimensions to the framework we have been building, because there are aspects of the structure and function of the self that deserve deeper treatment and that will make the practical tools more precise. Let me go deeper on the specific relationship between the unconscious mind and the generative drive, which is one of Dr. Conti's most important concepts and one that I want to make sure we cover adequately. The generative drive is the fundamental motivational orientation toward creating, toward building, toward contributing that underlies the experience of a purposeful and meaningful life. Dr. Conti describes 3 fundamental drives that operate in human psychology: the drive toward pleasure, which is the hedonic motivation toward gratification and comfort; the drive toward aggression, which includes not just hostility, but the more fundamental drive toward assertion, toward taking up space, toward overcoming obstacles; and the generative drive, which is the motivation toward building something that matters, toward contributing something of value, toward creating and growing in ways that extend beyond the immediate self. In a psychologically healthy person, the generative drive predominates, not the exclusive absence of the other drives, but the overall orientation is toward creation and contribution rather than toward pleasure-seeking or aggression. And the unconscious material that the framework helps people address is often precisely the material that is suppressing the generative drive or misdirecting it. Unprocessed trauma can turn the generative drive toward self-protection rather than toward genuine creation. Chronic anxiety can direct the aggressive drive toward defensive aggression rather than toward the assertive construction that genuine agency requires. And the predominance of maladaptive defense mechanisms can orient the pleasure drive toward short-term comfort seeking that substitutes for genuine generative engagement. The clinical picture of what suppressed generative drive looks like is instructive. It does not always look like depression in the conventional sense. It often looks like a low-grade flatness, a sense that life is fine but not particularly meaningful, that the motions are being gone through without genuine aliveness animating them. It looks like work that is competent but not inspired, relationships that are functional but not deeply nourishing, a general orientation toward getting through rather than toward being fully present and genuinely engaged. Many people in this state do not recognize it as a mental health issue because they are not diagnosably ill and they are not in overt crisis. But the absence of genuine generative engagement is itself a form of mental suffering, and it is one that responds to exactly the self-inquiry framework we have been discussing. I also want to go deeper on the parallel between physical health and mental health that Dr. Conti draws, because I think it is more precise than it first appears, and it has practical implications. In physical health, we understand that prevention is vastly more effective and less costly than treatment. The person who maintains cardiovascular health through regular exercise, adequate sleep, and good nutrition prevents the heart attack rather than surviving it and then trying to rebuild. The same logic applies to mental health with equal force. The person who develops a regular practice of honest self-inquiry, who tends to their character structure through the kind of curious attention we have been describing, who processes difficult experiences rather than avoiding them, is doing the equivalent of cardiovascular maintenance for the mental and emotional system. They are not waiting for the crisis to force engagement. They are building and maintaining the structural integrity of the self as an ongoing practice. And just as physical health maintenance does not require the person to be in crisis, mental health maintenance does not require the presence of significant psychiatric symptoms. It is appropriate and valuable for every human being at every level of current functioning. The person who is relatively well, who has a reasonably healthy character structure and reasonably adaptive defense mechanisms, benefits from this work not by resolving a crisis, but by deepening their capacity for agency and gratitude, by increasing the quality of their engagement with their life, and by building the resilience that will serve them when genuine challenges arrive. Let me also address the question of when professional help is necessary, because I want to be honest about the scope of what self-inquiry can accomplish and where its limits are. The self-inquiry framework we have described is genuinely powerful. Many people will be able to make significant progress with their mental health through the disciplined application of these tools, particularly if they do not have significant psychiatric illness and have not experienced severe trauma. But there are conditions and circumstances where professional support is not optional, where the intensity and the complexity of the psychological material requires the presence of a skilled, trained clinician to be safely and effectively addressed. Significant trauma, particularly early childhood trauma that involves abuse, neglect, or severe loss, typically produces disruptions in the unconscious architecture that are too complex to be navigated through self-inquiry alone. The character structure that forms in response to severe early trauma often includes defense mechanisms and relational patterns that are deeply entrenched and that have self-protective functions that make them resistant to self-directed change. A therapist who is skilled in trauma-focused approaches can provide the safety, the expertise, and the relational context that allow those patterns to be examined and changed in ways that would not be possible alone. Serious psychiatric illness, including major depression, bipolar disorder, schizophrenia, severe anxiety disorders, and eating disorders, requires professional evaluation and usually professional treatment. These are not conditions where self-inquiry alone is an adequate intervention. They involve disruptions in neurobiological functioning that require clinical assessment and often pharmacological management in addition to psychological work. And any situation involving significant suicidal ideation or risk of harm to self or others requires immediate professional intervention. The self-inquiry framework is not a substitute for crisis care. For everyone else, which is the majority of people, the decision about whether to work with a therapist or to engage in self-directed inquiry is not a binary choice between sick and well. It is a choice about what level of support and what type of engagement will be most effective for your specific situation. Many people benefit enormously from therapy even when they do not have significant psychiatric illness, because the therapeutic relationship provides a specific context that self-inquiry cannot replicate. The presence of a skilled, trained, genuinely caring other who can observe patterns that the person cannot see from inside their own character structure, who can provide the relational experience that updates the implicit relational templates that were formed in early development, and who can offer the specific kind of engaged, non-judgmental attention that facilitates the deep processing of difficult material. If professional therapy is available to you and you are struggling with significant psychological difficulties, I would encourage you to pursue it. The framework we have described today is compatible with therapy, and many people find that having the structural map makes their therapy more productive because they can more precisely identify what they want to explore and can more effectively evaluate their progress. I want to close with something that I think is the deepest and most important implication of Dr. Conti's framework, and it connects directly to what I described at the beginning of this episode as the target of mental health, agency, and gratitude. The framework Dr. Conti has built, taken all the way to its conclusion, points toward a specific quality of relationship with yourself and with your life that is both the prerequisite for and the expression of genuine mental health. It is a relationship characterized by honest seeing, the willingness to look at what is actually there without the distortions of the defense mechanisms, without the editing of the self-serving bias, without the numbing of chronic avoidance. It is a relationship characterized by genuine curiosity, the genuine interest in understanding what is happening inside you and why, rather than the contracted judgment that shuts that inquiry down. And it is a relationship characterized by engaged compassion, not the soft self-indulgence that avoids discomfort by telling yourself what you want to hear, but the genuine caring for yourself that insists on honesty, because honest seeing is the prerequisite for genuine change. That quality of relationship with yourself is not a permanent achievement. It is a daily practice. It requires the ongoing willingness to do what is uncomfortable rather than what is easy, to look at what is difficult rather than to look away, to engage with your actual experience rather than with the more comfortable story about it. But every moment of that practice builds the structural integrity of the self in ways that compound over time. And the person who has sustained that practice for months and years develops a relationship with themselves that is fundamentally different from the one they started with. Not because their circumstances have necessarily changed, but because they have changed in the specific sense of having more honest access to themselves, more agency in relation to their own patterns, and more genuine appreciation for the complexity and the value of who they actually are. That is the destination this framework points toward, and the journey is available to everyone willing to begin it. Thank you to Dr. Paul Conti for one of the most structurally useful and most personally applicable frameworks I have encountered in my years of doing this podcast. This is the first of 4 episodes in our series on mental health, and subsequent episodes will go deeper into therapeutic approaches, trauma processing, and the specific protocols that support ongoing mental health maintenance. If you found today's episode valuable, please share it with someone who is working on understanding their own mental health. As always, thank you for your time and for your interest in science. There are several additional dimensions of this framework that I want to develop more fully because the topics of anxiety, confidence, and self-narrative particularly deserve the additional depth. Let me go deeper on anxiety specifically because it is probably the single most prevalent mental health challenge in the modern world. The World Health Organization has estimated that anxiety disorders affect approximately 284 million people globally, making them the most common category of mental health disorder. And that figure does not include the far larger number of people who experience significant subclinical anxiety that does not meet diagnostic threshold, but that substantially impairs their quality of life and their capacity for agency. The research on the neuroscience of anxiety has advanced substantially in recent decades, and several findings are directly relevant to the self-inquiry approach Dr. Conti describes. The first is the role of the prefrontal cortex in the regulation of the amygdala-based threat response. The amygdala generates the initial threat signal rapidly and below conscious awareness. The prefrontal cortex, when it is functioning well, provides top-down regulation of that signal, contextualizing it with explicit knowledge about the actual level of threat in the situation. When prefrontal regulation is insufficient, amygdala activation proceeds unchecked, generating the full physiological and psychological anxiety response in situations that do not warrant it. Research by teams, including those of Joseph Ledoux at New York University on fear circuits and Michael Davis at Emory University on anxiety neuroscience, has illuminated these pathways in considerable detail. The practical implication is that anything that supports prefrontal function and prefrontal amygdala connectivity supports the capacity for anxiety regulation. This includes adequate sleep, which is the most robust modulator of prefrontal function available without prescription. Physical exercise, which increases prefrontal gray matter volume and improves prefrontal amygdala connectivity through mechanisms including BDNF upregulation. Mindfulness and contemplative practices, which have been shown in multiple research studies to increase the thickness of prefrontal cortex and to improve amygdala regulation. And a self-inquiry practice Dr. Conti describes, which builds prefrontal engagement with previously unconscious material and thereby increases the accuracy of the prefrontal regulation of anxiety responses. The second neuroscience finding relevant to anxiety is the role of prediction error in generating and sustaining anxiety. The predictive processing framework in neuroscience, associated with the work of Carl Friston at University College London and others, proposes that the brain is fundamentally a prediction machine that continuously generates predictions about incoming sensory information and updates those predictions based on prediction error, the difference between what was predicted and what actually arrived. In this framework, anxiety is generated when the prediction error is large and negative, when the world is consistently less safe or less predictable than the brain predicted. Chronic exposure to unpredictable threat, as in various forms of childhood trauma and in chronic environmental stress, trains the predictive system to anticipate threat even when it is not present. The anxiety that results is the brain's prediction of danger, continuously generated by a predictive model that has been calibrated by experience to expect it. The path to reducing chronic anxiety in this framework is updating the predictive model, which requires new experience that is inconsistent with the prediction of danger. This is precisely what exposure-based treatments for anxiety achieve. They provide the brain with repeated experience of the feared situation without the feared outcome and gradually update the predictive model to generate lower threat predictions in that situation. And the self-inquiry that Dr. Conti describes supports this update process by bringing the historical material that established the predictive model into conscious awareness, where it can be examined and recognized as historical rather than current, which itself supports the updating process. On the question of confidence, I want to add the neuroscience of self-efficacy and its relationship to the character structure. Albert Bandura's self-efficacy theory, one of the most thoroughly researched constructs in all of psychology, proposes that the belief in one's capacity to execute the behaviors required to produce specific outcomes is one of the most powerful determinants of actual performance. And the four sources of self-efficacy that Bandura identified: mastery experiences, vicarious learning from observing others, social persuasion from people whose opinions matter, and physiological states during performance, all have direct relationships to the character structure and the defense mechanisms. Mastery experiences, the accumulation of evidence about one's own competence through actual achievement, are the most powerful source of genuine self-efficacy. But the character structure determines whether those experiences are accurately integrated or whether the defense mechanisms prevent them from being absorbed. A person whose defense mechanism is primarily avoidance will have fewer mastery experiences because they avoid situations where failure is possible, which means situations where growth is possible. A person whose defense mechanism is primarily rationalization will explain away their mastery experiences as flukes or as externally determined, preventing them from being integrated as evidence of genuine competence. So building genuine confidence requires both the behavioral component, actually doing difficult things and accumulating evidence of competence, and the structural component, developing a character structure that allows those experiences to be accurately integrated rather than defended against. The negative internal narrative deserves one more specific treatment, which is the distinction between self-criticism that is genuinely useful and self-criticism that is purely harmful. Not all negative self-directed thought is maladaptive. There is a form of honest self-assessment that involves acknowledging genuine errors, genuine limitations, genuine areas needing growth, that is actually an expression of healthy self-awareness and that supports improvement. The distinction is between evaluative self-feedback, which is specific, accurate, and forward-looking toward what can be changed, and the negative internal narrative in the pathological sense, which is global, vague, past-oriented, and organized around fundamental judgments of worth rather than specific assessments of behavior. I failed at this specific task, and here is what I can learn from that is evaluative feedback. I am a failure is the negative internal narrative in its pathological form. The evaluative feedback supports growth. The global judgment of inadequacy suppresses it by producing the very states, anxiety, low confidence, avoidance, that prevent the engagement with difficulty that would support genuine improvement. Developing the capacity to distinguish between these two types of self-directed thought, to maintain honest evaluative feedback while interrupting the global negative judgment, is one of the most practically important skills in mental health maintenance. I also want to address the concept that Dr. Conti calls the emotional abscess, which I consider one of the most evocative and most clinically precise metaphors in his framework. An abscess in physical medicine is an area of infection that the body has walled off. The immune system contains the infection through a membrane of inflammatory tissue, preventing it from spreading, but also preventing it from being cleared. The abscess continues to generate pain and systemic effects, even though it is compartmentalized, because the infection is still there and the inflammatory process is ongoing. The emotional abscess is the psychological analog. It is an area of psychological material, unprocessed grief, shame, fear, conflict, that the defense mechanisms have walled off from conscious awareness. The material is contained enough that it is not overwhelming the conscious self, but it is not gone. It is generating ongoing effects. The chronic low-grade anxiety that seems to have no clear source, the recurring pattern in relationships that keeps producing the same painful outcome, the persistent sense of flatness or meaninglessness that coexists with a functional life, the specific topics or memories that the mind consistently steers away from. These are the signals that an emotional abscess exists. And the treatment, like the treatment of a physical abscess, requires engagement rather than avoidance. The abscess needs to be drained, the infection cleared. In psychological terms, that means the walled-off material needs to be brought to conscious awareness, examined, processed, and integrated. The defensive wall that was containing it needs to come down, which is uncomfortable and temporarily destabilizing in the same way that surgical drainage is uncomfortable. But the alternative, leaving the abscess untreated, is the ongoing cost of the symptoms it generates indefinitely. The specific practice I want to offer for identifying your own emotional abscesses is this. Sit quietly for a few minutes, not to meditate in the formal sense, but simply to slow down the surface activity of the mind enough to become aware of what is below it. Notice what topics your mind avoids. Notice what memories or thoughts produce a rapid, almost automatic shift of attention towards something else. Notice what areas of your life you are consistently vague or dismissive about when you reflect on them. Notice what makes you feel a specific quality of internal tightening that is different from ordinary discomfort. These are the entry points to the abscess. They are not pleasant to attend to, which is precisely why the defense mechanisms are operating there. But the discomfort of attention is temporary, and the cost of continued avoidance is ongoing. The willingness to turn toward rather than away from these entry points is the single most important element of the self-inquiry practice. Let me end with something that I think is genuinely important and that does not get said enough in discussions of mental health: the relationship between mental health and relational life. The quality of your close relationships is both a consequence of your mental health and one of its most powerful determinants. The research on the social determinants of health, perhaps most famously represented by the Harvard study of adult development, the longest longitudinal study of adult life ever conducted, has found consistently across 80 plus years of follow-up that the quality of close relationships is the single most powerful predictor of health and well-being in later life, more predictive than any specific behavioral or medical variable. And the quality of close relationships is profoundly shaped by the character structure and the defense mechanisms we have been discussing. A person who predominantly projects their internal states onto others will have relationships that are chronically distorted by those projections. A person whose character structure is organized around avoidance will have relationships that lack the depth that genuine intimacy requires. A person with significant unprocessed trauma will carry the relational templates formed in that trauma into their adult relationships, often unconsciously recreating familiar but painful patterns. The self-inquiry work is not separate from relational life. It is one of the most direct paths to improving relational life because it addresses the structural sources of the relational patterns that prevent genuine intimacy and genuine connection. As you develop more accurate self-knowledge, as the defense mechanisms become more adaptive, as the character structure becomes more flexible and curious, the quality of your engagement with the people in your life changes. Not because you have adopted better social skills or communication techniques, though those have value, because the actual person showing up in your relationships has changed, has become more genuinely present, more accurately perceiving, more capable of genuine reciprocity. And that change in the person changes the quality of the relationship in ways that cannot be faked and cannot be produced by surface-level behavioral modification alone. The framework Dr. Conti has provided today is a map. The territory it describes is your own psychology, the specific architecture of your conscious and unconscious mind, your specific defense mechanisms and character structure, and the specific ways those elements are supporting or impeding your capacity for agency and gratitude. Maps are not the territory. Reading this map does not replace the exploration of the actual terrain, but it makes the exploration more navigable, more directed, less likely to get lost in the surface details while missing the structural sources of the patterns you most want to understand and change. Thank you for your time today. As always, thank you for your interest in science.